Good afternoon, everyone, and thank you very much for joining us again here today, this afternoon, for plenary number 4, which is going to be all about how can we ensure that we are on the right path to equitable and sustainable digital health for the future of the European health systems. I'm Natasha, Azzopardi Muscat, and in my role as Director for Health Systems and Policies at WHO Regional Office for Europe, I'm also responsible for digital and data. And of course, as we saw in our Digital Health Symposium, the beginning of September in Porto, one of the key issues that continues to arise whenever digital solutions are discussed is it's not just about having the right devices, a stable net interconnection, and interoperable health systems, but it's about making sure that the people who need to use those health systems, be they health workers, be they citizens, be they patients, be they carers, can access them and can use them competently and with confidence. And this could be telemedicine, it could be mobile health apps, it could be wearable devices, any kind of solution. And the paradox is that often the people who can stand to benefit the most are the ones who are least well equipped and competent to use those solutions with confidence. So our collective efforts need to improve to make solutions and design solutions that are easy to use and really empower people to take advantage of the technology. And it's part also of what I like to call the democratization of health systems, as we give people the potential to be able to do so much more for their own health. But where are we? Our review on equity in digital health technology within the European region shows clearly that digital health tools are still not equally accessible to all communities. Geographical location, socioeconomic status, age, all contribute to what we call the growing digital divide. And if we are to bridge this divide, we need to ensure and recognize the value of a well-structured approach to digital health education. But actually, from a survey, which you'll hear about more in a moment, amongst our 53 member states in the European region, 52%, just slightly more than half, report that they have digital health education policies or strategies or plans. And 56%, again, just a little bit more than half of these member states have implemented inclusion plans. So there is a gap to be closed. Of course, we at WHO Europe are urging all our member states to establish inclusive plans and policies. And in today's session, in the next hour, we will have insightful discussions, share best practices, and learn a little bit more from organizations and countries about how they are promoting equity and sustainability. So to kick off, I would like to invite my dear colleague, Davies Novillo, who is the Regional Advisor for Data and Digital Health, to give us a lightning presentation on a really rich source of data to set the tone for our plenary today.
Thank you so much, Natasha. Good afternoon, colleagues, and thank you so much for making to this plenary after lunch. We know how difficult it is to join a session after lunch. So in Spain, my home country, this will be enough time. I hope that I can give you wake up. This video you can see in the background is September 20, so 1 year ago. All our 53 member states agreed to adopt a strategy, a regional action plan on digital health for the period 2023-2030. Today is not the day to talk about this action plan, but just for you to know that there is an overall agreement for these 53 member states in how we should move forward about digital health in the European region. In this presentation, I'm going to briefly speak about three topics. One, some of the findings of the review that we conducted thanks to Public Health Wales, and Dr. Alisha Davies is here, the leading author of this review. Also, some of the data of our findings of a survey that we conducted last year, and the report was published this year, like 2 months ago, with data from the 53 member states about digital health. And then some recommendations on how we see the way forward working on digital health and equity. This is very well known, right? Digital health is not accessible to everyone equally, right? We knew that, so what we did is to look at the available evidence to know how we can reinforce these findings to really want to make that point very clear. So what we did, and again, Dr. Davies will speak about that later in the panel, it was to look how digital health, how the access, the use, and the engagement with digital health technologies are among the population. So when it's about the access, we saw that white and English-speaking population has higher access to digital health technologies. When it's about the use, we also saw that English, white-speaking population living in urban areas, usually younger population, has a higher use of digital health technologies. And then we found that when it's about engagement, that for the evidence that we found is mixed. So there are no, we can assume that that is in the same line that we saw with access and use, but there is still some, we need to conduct more research to see how the engagement is doing when it's about inequalities. Looking at the results of the report that we conducted last year, this is a very rich data report, so I will really encourage you, and you will have the QR code later in the presentation, look at the findings of this. So these some facts that I'm going to share today, just some of them, of the very this rich, data rich that I mentioned. So we were asking the member states if they have a digital health policy or a strategy overall. And it's very encouraging that from the 53, 44 already have a digital health strategy or policy. We asked if they have it. We didn't ask if they are implementing it. So that is a caveat. And next time that we talk about the report, we make this very clear so everybody knows about the limitations, about these questions and about the report. From these 44 countries, we ask about the priorities included as part of this digital health strategy. And we saw that almost all of them included that enhancing accessibility, quality, safety, and efficiency are strategic priorities as part of this digital health strategy. We also saw that for 75% of them, they included measures to ensure equity in accessing digital healthcare services. So looking in a bit of detail in this 75%, what we saw, we were asking about the measures that they were using to reach and to close this gap about equity and inequalities about digital health. And we saw that for most of the countries, reducing gaps is about having good, reliable internet connectivity and improving digital literacy skills in the whole workforce in the population. If you ask me, if you ask us as WHO, we know that that is not enough. So just having internet is not enough when it's about how we are training and how we are deploying these solutions. We have seen, I have my parents, my dad with diabetes trying to manage the glucose with these new devices, but he needs to know how to use it, right? So try to extrapolate that to any digital solution that we try to implement in the population without the proper training and proper skills. We also saw that some of the countries mentioned that telemedicine is something that is reaching the gap to provide access to digital solutions. That doesn't mean that this is free, of course. But we can see that these three actions about providing good internet connectivity, enhancing digital health literacy skills in the population and the health workforce, and then expanding the access to health services through telemedicine are the recurrent measures that countries mention when talking about bridging this gap about equity. We also know that people with higher digital literacy skills have better health outcomes, and they can be more empowered when it's about managing their own health. That is something that also we found about this review, and also overall is the perception that we have already had. When it's about more data from this report, Natasha mentioned this, we were a bit surprised that, and it's a red flag for us, that only a half of the European region has digital health literacy strategies. So we are investing badly in deploying digital health solutions, but then when it's about how we are deploying the digital health solutions, we don't have a strategy for that. So there is a real gap that we need to continue working all together to try to address. And also we saw that only a half of the region has digital inclusion plans. So we can see that everyone is talking about digitalization. There is no politician without mentioning digital in the plans. But then when we see how this is implemented, we see a clear gap that we need to work together to address. The way forward, what we have in mind, and of course, ideas and comments are welcome. First of all, as part of this review that we conducted, we know that we need to develop a framework in how to measure inequalities in digital health. There is no such a framework. So there is the time, and we're already late, to develop this tool that will help us to support also countries in how to measure digital inequalities. Also, we are working closely with the London School of Economics, and Robin Van Kessel is here in the audience. We are working with the London School also to conduct this digital determinants of health, to really have this understanding of how digital is really having a clear impact on the population, as the social determinants or any other determinant that you can think about. We also know that we can map inequities when it's about digital infrastructure, something that, in my experience working in the Latin American region years ago, is something that did really work, to know if the healthcare services, they have internet connection or not. That is something that some of the countries are doing, but others not. So that is something that we can also need to do to really know where there are these difficulties and limitations, right? And then the most important one, that is to use an inclusive and participatory approach when developing digital health technologies. And that is not directly, is for the population, how we engage the population when developing these digital health solutions, but also in the health workforce. One of the main failures, based on the evidence, when deploying digital health solutions with the health workforce is about not involving them. I think that many of you maybe have been involved in developing electronic health records. So there is evidence when you try to deploy and develop a tool without the input of the health workforce, right? And also how the health workforce also needs to treat the patient when he's in front of the computer. I mean, I know that this is on news, but this is still a problem, right? So this is somehow what we have in mind. This is just a snapshot of what is happening. I'm pretty sure that the panel that is going to happen now is going to bring more light about what are the real challenges about inequalities. But if you have any comments or idea, we have a stand outside, so please do not hesitate to approach us, to any of us, and just brainstorm with us, okay? So we're an organization that really listens to you, so please take that opportunity to do it, okay? Thank you so much.
Thank you so much, David, for really giving us this lightning overview on this really important topic. And now we come to our panel. Let me introduce our panelists briefly. We're delighted to have with us today Dr. Alisha Davies, who is the Head of Research and Development in Health and Care Wales and is the author of our review on equity and digital health. We're also really delighted to have Dr. Irini Agapidaki, who is the alternate Minister of Health for Greece. But Irini is actually one of us and has been several times at this conference. Today we welcome her here in a new capacity. Thank you. We also have Mr. Jerome de Barros, who is a policy officer in the digital health unit of DG Santé. And we're very pleased that you are able to join us because we are about to embark on a large joint project together. And of course, my longtime friend, Professor Anna Odone, who is a full-time professor at the University of Pavia and the chair of the digital health section in EUPHA, which we founded how many years ago, Anna, now? Is it 6 already?
Not 6, but
almost close to that. So, without further ado, Alisha, can I come to you first and ask you about the scoping review that you led? What would you say are the key findings related to access, use, and engagement? David showed us that slightly a complex slide. Translate that to us with ready take-home messages from your scoping review.
thank you. Thank you, and thank you ever so much for inviting me here to join you today. The scoping review, there was a team, my team as well, in Public Health Wales that helped to review this, but it was kindly supported by WHO Europe. And we looked at the extent of the literature over 6 years, so 2016 up to 2022, to the extent to which equity is considered in digital health interventions and how that's reported in different studies. We considered it across those 3 different domains because digital health isn't implemented in an isolated system. Digital health innovation, we need to think about access as one challenge, the infrastructure that sits under it, the extent to which people have the skills, as was mentioned, to use the digital technology, and lastly, the level of engagement. You may have the access, you may have the infrastructure and the skills, but actually you still might not be interested in engaging with health on a digital health system. So we had those 3 domains, and we looked at 10 or 11 different equity domains using a framework called Progress Plus, and tried to map that across the literature that we find. So that was the picture that you saw up there. A couple of the key highlights from it. The first is the challenge in defining digital health technologies. We do have definitions, but actually it's still very variable. And it's a real mix of different digital health interventions. We weren't looking at one particular type of digital health intervention. We wanted to look across the broad spectrum, the extent to which equity is considered. The second thing is that equity, the way it's considered, hugely variable. Much more literature in the demographic dimensions of equity, like age and gender, very little in some other areas, such as disability, or more in the underserved groups as well too. And one of the key challenges in the literature is that actually when it comes to reporting differences in access, use, or engagement with digital technology, there's very little that actually compares the differences between those different groups in one study. So it makes it more difficult to understand what works, where digital health might be a solution for actually groups that are underrepresented in society or tackling health inequalities, but also understanding where it doesn't work. Some of the key groups, whenever it came to access, just to put it into numbers, some of the figures from the UK, in 2018, 10% of the UK population don't have access to the internet at home. That equates to 5.3 million adults. In Wales, in 2022, 6% have no access at home. So things are getting better, but that in Wales still equates to over 180,000 people. So this isn't a small problem. So with access, we find that individuals without disability or complex health needs, those of white ethnic origin, or English as a first language, much better access to technology to support digital health. Second, in terms of the use of digital health technology, we saw much higher use amongst younger individuals, those of higher education, higher socioeconomic status, white ethnic origin, English speakers, and those living in urban areas. But there are some examples where digital tech is being used to help address health inequalities like in more rural areas or reaching out to more vulnerable populations like homeless people with lived experience of homelessness. Some of the key themes, just to summarize, is that reporting and examining equity in digital health solutions is really lacking. It's highly variable. We tend to look at one dimension of equity as a singularity, rather than considering actually how they overlay with each other. Very little consideration of the complex systems of digital health. And one of the key things that comes out in all of the papers that we looked at is the importance of co-production and making sure that digital health is really led by the user's needs to make sure that then you succeed in terms of the engagement and the digital health interventions.
Thank you, Alisha. And let's particularly come back to this issue of co-production, because it's one of our themes which we'll be taking forward to our health systems meeting in Tallinn. And a lot of what we heard from Alisha is probably what we were expecting. So I'll ask you to think about, when I come back to you, what surprised you most from your review. But I'd like to come now to Anna. Anna, how can we really ensure that we take up the benefits of this digital health revolution whilst respecting equity? You see, I haven't made up my mind completely yet on this, as to whether it's those who are less able to access digital health because they're poorer, older, etc., which will be left behind, or whether, fast forward a few years from now, we will end up with a situation where those who are poorer and who are less advantaged will only get the digital equivalent and won't get to see the human. So I'd like to hear your thoughts about this.
Yes, you're right. I mean, in Alisha and colleagues' work, they report that within a deprived population, 49% of subjects do not use any kind of digital tool to support their health. And this 49 isn't just a number. There are people behind 49%. Meet one, Emma. She is 58 years old. She came to Italy for work. She has diabetes, and now she has limited mobility because of a car accident she had over the summer. Her life is juggling between a very low-paid job in a local canteen, taking care of her parents, while also trying to take care of her own health. So she faces constraints and limited resources, and the daughter told her there is an app she can use to manage her diabetes, her diet, her treatments. Problem is that her phone does not support this app, and she doesn't trust technology that much. So what's the problem? She is missing an opportunity that derives from available digital solutions to make her life easier and better. And so that is a very simple but true example of what you were asking, Natasha. So how can we address issues of equity while harnessing the digital revolution momentum? And I would like to make two simple points, but I believe they're important. Point number one, we know how to identify and measure what we now call, as David would mention, the digital determinants of health, related to access to digital health, related to literacy, related to availability of digital infrastructure such as internet connections. And we know from decades of evidence gathering around determinants of health how we can map them, not just because, but in order to have the data to inform the planning and implementation of targeted solution that targets the needs of all. And the second point I wanted to make is that I really think we need to consider time in technology adoption. Again, nothing really new. This one is the adoption innovation curve that was designed by Everett Rogers a few years ago that describes how different types of people adopt technology, in this case, technology for health, over time. And you see you have the innovators, you have few early adopters, and then you have us, so the early or late majority, and then we have the laggards. And I do believe that Emma is there. So she will eventually, but very late, access to technology when maybe it's too late. So my point being is that we have to align health needs to available digital solutions. We have to align supply with demand. And we cannot leave the technology market grows without controlling it in order to benefit for all. And I think to do that, we need to have a system in place with all the different pillars. We have to have political commitment, we need to have a regulatory framework, we need to have, of course, technological infrastructure within our health services, research and development, but last but not least, we also have to monitor and evaluate how we use this to support the health for all.
Thank you, Anna, and thank you again for giving us this human picture. And I mean, 49%, we're talking about 1 out of every 2 individuals. So imagine you have an apartment block, 1 out of every 2 apartments. Imagine you walk through a street, it's 1 out of every 2 tenements that you might have on this deprived road. That's not a little. But I'd like to perhaps share with you some good news. Let's hope it does manage to happen. It's on Davies' shoulders. We have set out a call for what we call the Strategic Digital Health Partnership Initiative. I hope I remembered that right. Where this is what we are trying to do precisely, bring around the table suppliers, patient representatives, health worker representatives, to bridge this gap between the needs of real people. I always like to say, and I'm sure some of you have heard me say this before, that a lot of digital solutions are developed by young, handsome men to be used in the health sector by aging women like myself. And there's a gap there, an obvious one. But let me come to you, Jerome, because of course, the way Anna has given us a list of things to do, I mean, let's face it, the European Union, the European Commission is so well positioned to regulate, to legislate, to bring people together, and yet sometimes it faces some real practical difficulties in trying to make this vision a reality. And one of the big projects that you are currently trying to see through, which is very ambitious, and which of course has encountered not a few roadblocks, is the creation of the European health data space. For a lot of people, myself included, this is quite esoteric. How is this going to help people that are statistics in Alisha's report and faces and humans like Anna showed us?
Thank you, Natasha. So first, perhaps for context, the European Health Data Space is a proposed regulatory framework by the European Commission for the use and the reuse of health data for providing care, but also for supporting research, innovations, regulatory purposes. So we're trying to make the most out of the data. One of the challenges that we had identified, firstly, is access to data. It is limited and very unequal, depending on the country you're in, whether or not you do have access to your data or not. What do you have access to? What types of data do you have access to? In which format? And importantly, what can you do with it? How much control do you have over this data? So this led us to prepare the proposed regulation that is currently being negotiated, where for access to data, what we are proposing is to make it possible for every European to have access to this data in a common format and being able to exchange it. So this is already happening. That is, we have the My Health at EU platform. This is an infrastructure that enables healthcare professionals in participating countries to exchange information. That is, a patient summary and a prescription at the moment. It is only limited right now to countries that voluntarily engage with the initiatives. What the proposal is saying is we want this to be mandatory in the 27 countries. We want everyone's data to be accessible by professionals so that we can have within the country and across border care informed by relevant data, but also by people themselves if we want them to have control, to be able to use this data, to be able to have an active role in their care. They should be able to have access to this data as well. So this is what we are proposing, and we want to make sure that really every citizen is covered.
So this will, of course, address issues around geographical disparities within the European Union, at least, one hopes. Thank you for explaining that, and good luck with the next hurdles you will be encountering across the way. Let's try to make this happen, and let's bear in mind what we've been hearing as far as possible, to listen to the health workers, to the patient representatives, to make sure that what we do come up with works for them. Let's take these arguments within the country now. Irini, can I come to you? I know that this is a topic which is very close to your heart. And can you tell us a little bit about what you are doing in Greece to ensure that amongst the ambitious reforms that you are promoting, also to address healthcare disparities in general, whether they are geographic disparities or others, that you are embarking, I know, on some important initiatives to keep digital health equity in mind?
Thank you, Natasha. It's an honor and a pleasure to be here with you today. For me, EUPHA is like home. I think every single public health expert around the world feels like home when you are back with your community, public health experts. For the progress made in Greece to date, we have recently launched the My Health app. It's a mobile phone application accessible by all Greek citizens using your login credentials unique to each individual's digital identity and standardized across all digital government platforms. This digital health platform serves as a national electronic medical record for all citizens in Greece, and they can access medical records with data about personal demographic information, medical history, vaccination records, lab results, prescription, prior health provider visits, etc. We're now proceeding with more complex imaging diagnostic data, including electrocardiograms, echocardiograms, X-rays, MRIs, CT data. It's a very demanding but necessary next step in the expansion of our national electronic medical record system. Yet the current ability of all Greek citizens to access their own digital health information is a key first step to promoting digital health equity in Greece. The importance of this initiative, I think, is enhanced when one takes Greece's geography into consideration, which returns the implementation of traditional healthcare delivery models, regions, and more specifically, if we take into account, if we consider the mountainous northern Greek regions, which are paired with an expansive archipelago, including more than 200 inhabited islands, with our citizens spread throughout. So by extent, even access to one's medical records previously served as a fundamental barrier to overall health equity that we have overcome with the launch of My Health app. While developing this app, we recognize that pooled digital literacy, that's the #1 factor you have already mentioned, particularly among the elderly citizens, the case we have already made today, still limits digital health equity as it pertains the access to the national electronic medical record. thoughtful implementation of this initiative was pivotal in at least partially addressing this issue by minimizing the platform's front-end complexity, ensuring a more user-friendly experience. The launch of this national information campaign served to popularize the My Health app and educate our citizens in its use, further expanding its impact. I think at the same time, we have placed strict operational protocols, we comply fully with GDPR regulation, and now we are proceeding with a more complex strategy that has it's very focused to address social inequalities and brings together the artificial intelligence, machine learning, algorithms, and our plan for the AI integration of our electronic medical record system. It includes, of course, health digital equity on the front and center. I want just to make the case, Natasha, for 3 key components. We believe in Greece, it's the evidence that we use that play a key role in the adoption of AI, ML into the health systems and try to bridge the gap between the traditional healthcare workers' modus operandi, the traditional healthcare users' modus operandi, and the nowadays way that we want to proceed with things. So we have the model development, explainability, and predictive accuracy that I think that are the 3 key determinants when it comes on how we can translate digital health tools into practice for physicians and the citizens as well. So I'll stop here. I think we will have the opportunity to get back to these points.
Very good. Can I push you a bit further? Because, this sounds great, really. But can you share with us perhaps 1 or 2 examples of the hurdles and barriers? Because I think this is really what people want to hear. They are, like you were a few years ago, dealing with the science, but now you're actually sitting on the other side and you're dealing with the real problems. You see, we think we have all the solutions, but then when you're sitting in the chair where you have to make the change happen, what are the kind of problems that you're grappling with? And what's your ask to the researchers out there?
Well, since we are in Dublin, I think we have a perfect fit of the title of the play of Oscar Wilde, The Importance of Being Earnest. We talk about digital health equity, how we can solve problems in the 21st century environment, which is more complex. I must admit, Natasha, that when you work in the academic sector, things are very different. That's why I value so much, I appreciate the work of the public health policy and politics of EUPHA, because it brings together, it's a platform to bring together people from the academic sector and political actors. Believe me, it's a total different frame of mind, being a politician or act as a politician, from being, a scientist, a researcher, an academic actor. It's very different, and it's very important to convince politicians. I do not consider myself as a traditional, let's say, model of politician, and that's why for me perhaps it's easier to adopt the solutions, but for other people perhaps it's not that easy. We have to convince them. They need to have a combination of quick wins, and also we need to convince them to invest on mid and long-term outcomes. That's why I insist on evidence-based public health, and that's why I insist on having these 3 key determinants, the model development, explainability, and predictive accuracy as a guide for our work from now on in Greece. I won't spend time talking about model development, but allow me to talk a little bit about explainability and predictive accuracy, because it has much to do with how clinicians can actually adopt this kind of tools. So ensuring digital health equity in an AI-integrated electronic medical record is not limited to predictive model development, but also applies to the interpretation of the model predictions. So indeed, prior studies have established that clinicians view explainability instead of predictive accuracy alone as one of the limiting steps to incorporate artificial intelligence and machine learning models output into their routine clinical practice. Additionally, the explainable models reveal which features influence a model's predictions, and this transparency, in turn, allows for the identification of bias during the model development. So detection of bias paired with the exploration of fairness metrics, including demographic and geographic parity, for example, are key to ensuring algorithmic accountability and promoting digital health equity. Lastly, explainable models can provide insights into individual patient decision-making, hence assisting healthcare providers in personalizing treatment strategies. And for predictive accuracy, we're planning to launch in Greece a huge program, a nationwide program, that brings together telemedicine, AI, machine learning to prevent premature deaths, avoidable, preventable deaths from cardiovascular disease. We have, as I said, 200 islands inhabited, so it's very important for us to provide remotely emergency medical care to patients. So we will going to use wearables. Imagine the case, wearables to rural populations. You know, interestingly, we don't have a match between the educational status and digital literacy or health literacy. We have a relevance, of course. There is a relationship between these two different variables, but in many cases, we can see rural populations to be very familiar with digital technology, even when it comes to My Health app in Greece. Instead of having familiarity with other kind apps, and this has to do with one traditional, and I would say, always important factor, the patient-doctor relationship. So it's important if you have your physician to train you how to use the wearable. The wearable will provide continuous data about arrhythmia, about the cardiac function, etc. So we will gather all this data, and we will be able to know the compliance when it comes to chronic patients, the adherence to treatment, whether a patient needs to have emergency care. So we will be able to avoid a number of deaths that now is unfortunately the case in Greece, especially when it comes to remote areas or the islands or the mountainous regions that we have in Greece. So I believe that this element is one of the strategy, one component of the strategy that we have in Greece to address health inequities. Is important because it brings together, cutting-edge technology, the very essence of the technical components, and how we're going to proceed with the barriers for health equity for each and every of these components, and also evidence-based public health. I think this is the most important thing. We should not forget that at the end of the day, we work not for the people, but with the people.
Thank you, and I think that's really clear, but what struck me very much was the role also that the health workforce plays in educating and giving the confidence and the trust to the people. So thank you also for spotlighting that, and good luck with the implementation of these important reforms, which also, if successful in the Greek islands, could be so important even for other parts of the world that have such archipelagos to learn from. Alisha, I hope you've had time to think about your most surprising finding. Let me come back to you on that, and then I'll ask you another question about the framework.
Thank you. The most surprising finding, I think, naively, I thought, there'll be lots that we can draw from in this. But then whenever it came down to the review, looking for more robust evidence, good studies that have really explored digital health and equity, actually, there wasn't as much out there as I thought. So it what surprised me was that it's by doing it, I'd identified it as a gap in the evidence, but also the need for a sense of urgency to really start to think about how do we build the systems from the development through to the evaluation of tools that can help to capture some of this. we did a survey representative survey in the Welsh population just after COVID, asking people to what extent do they want to engage with digital health technology for the future. And over half want to use digital tech to either manage their own health, book appointments, receive certain areas of clinical care. So the public are, not everybody, but some of them are there already. So how do we do that?
So this is a very typical case. We don't have enough evidence, and in the list of recommendations, the first one is that we need more research. But policymakers like Irini can't wait. So any recommendations that you could give us at this stage for how we move to this common framework until further research is being done?
I'm not sure if it's research, but it's embedding evaluation into practice. And to be able to do that, the most important thing, I think, is it comes back to the data. So how are you building the data infrastructure that sits underneath mHealth or other solutions that captures some of the domains of equity in there, which enables you then to understand differences in uptake, but also differences in outcome. Because we'll be thinking about digital health solutions, but it won't just be that potentially, that won't be your only route to receiving that care. You'll have analog routes as well too. And we want to make sure that different populations receiving care through different channels don't have differences in outcomes. We can't do that unless we've got the data that underpins it. There was a publication a couple of weeks ago that is called Standing Together, and actually it's about the data divide, and reflecting on the AI element in particular, it's highlighting the importance of two things. One's the underpinning data that's used to develop tools, or the data systems that we are putting digital health tools on, and the second is the transparency about how we're using that data to inform innovation. And I think we can move in the research space. I am a researcher at heart. I'm also a pragmatist, which doesn't always sit well. But we can move into a system where actually the research moves faster, the evaluation moves faster within an innovation cycle to help capture evidence, share best practice, share learning, to help everybody then to move further forwards.
So data and the capacity to really have the data to know what actions we need to take. And let me make a plug for another session coming up immediately after that really looks at population health management and primary healthcare. And the starting point is the data. And let me come back to you, Jerome, because one of the benefits of the European health data space is actually around the reuse or the secondary use of health data. So again, how can we use this to support more equitable healthcare systems?
No, you're very right. And when we look at this reuse of health data, I think any researcher here who had to apply to access any kind of data knows how long, how complicated it can be, even more so when you're aiming to access data from more than one country. You have different frameworks. I'm speaking here for the European Union, different frameworks, different time frames, and different decisions sometimes. So when we prepared the European data space, when it comes to secondary use, we proposed a harmonized framework on how to reuse this data for specific purposes, for innovations, developing these digital health solutions that we're talking about.
Who should be able to reuse this data, Jerome? Should everybody be able to reuse this data?
In our view, any user, anybody that has a right research questions, a right purpose, that's why we're setting specific purpose for which this data should be made available. Performing research, develop these solutions, for example, to study the interventions that we have highlighted here, to study the impact of policies, for example, the ones like Irini proposed. You need data. You need to be able to have access to this data. You need a clear framework. You shouldn't be able to wait too long. And also, when we prepared it, we wanted to make sure that what we're proposing is relevant for researchers innovators, policymakers across multiple fields, which is why the list of data types that are included in our legislation is very broad. Clinical data, genomic data, research data, obviously, but also administrative data, claims, or around determinants of health as well. So we try to, with our framework, as much as possible, meet the needs of...
And will you have different categories for the different types of data when it comes to how they can be reused and accessed? Because I think these are the kind of questions that people are asking also to ensure that they can really have trust in this health data space.
So when it comes to trust, we made sure to propose a series of safeguards as to how you access this data. When I mean accessing, we're not talking about downloading this data at all. It is, first of all, only in a secure environment, in an anonymized or pseudonymized format. And throughout the process, we make sure there's all the right transparency measures taken as well. Also, when it comes to the publication of results, if you requested data for the European data space, there should be clear, visible results for the community, but also for general public.
So you're promoting the accountability?
Promoting the accountability, which is why when we developed it, we tried to make sure that the data of as many people as possible would be represented. We're using public interest as the legal basis, for example, to make sure that everyone, including underrepresented populations' data, is made available by default. That we do not have any other systems where only those that are in the know or more aware of the potential that having your data used could have. So if you have an opt-in system, obviously only those that are aware of the benefits would be opting in. We want it to be more inclusive.
Thank you. I would like to leave the final word to Anna, because of course here is the community where we're going to try to together work to make things happen. But let me come back to David. David, we've heard a lot from our panelists. There's a lot to unpack. What can we do as WHO? What are we going to be doing in the next few years to address some of the points that we've heard this afternoon? Besides our project, perhaps you might want to say a couple of words about that we will be launching shortly with the European Commission.
Thank you, Natasha. I mean, just listening to all of you, I am panicking, basically, right? And I assume you too. We know about the data and the challenges about data, right? So we're looking at the SDGs, right? The Sustainable Development Goals. We already know that we don't have good data, right? And we are talking about achieving the SDGs without having proper data to know if we are going to achieve the SDGs, right? So we need to do better when it's about data, and we have plans for that. In the case of our office, we have the European Programme of Work, the measurement framework, and we are very committed to move with this data part that is very needed. Just to give you an example, mental health. It's completely unacceptable that we are measuring mental health due to suicide rates, right? Just as an example. So we need to do better when it's about measuring the priorities that are happening and that are relative, not only for the European region and at the global level. When it's about digitalization, I would say that we are fully committed to work with all of you about this framework to measure inequalities and how we can really move forward in this direction so we are not leaving people behind. We know that artificial intelligence is here to stay, but we also know that our countries are still not prepared, not all of them. Right? So we are fully committed also to move in this direction, and we have already published some technical guidance about regulation on AI that has been led by our colleagues in WHO headquarters. So it's interesting time for all of us, right? We are all the time talking about we need to do this, we need to do that, but colleagues, the we is all of us, not just WHO. So you need to know that. And we are counting also on you to deliver on that. And the time is now. So,
thank you. So Anna, as president of the digital health section in EUPHA, what can EUPHA, what can our constituency do? And then what are your asks to us as WHO, to your European Commission?
Well, EUPHA is us, right? We do have roles, we have bodies, we have a structure, but the true fuel, the true power of EUPHA, as you were mentioning, is our European public health community. And which role does this community have, also towards WHO and towards European Commission? I do believe that this role is mainly shaped around two aspects. Number one, the values of public health that we all share. And we know how much in need we are of promoting those values of public health, of prevention in European member states nowadays. And number two, we have the skills, the competence, the experience to act in public health policy, in public health practice, and in research. How can we use such two big things that we have? So we started, David, talking about equity. At the beginning, the narrative was that digital health would have helped us to decrease inequalities in health, and now we are realizing that more and more digitalization might threaten equity in health. And so what can we do as EUPHA? Well, the question was about advocacy, perhaps, but we don't have to forget that the EUPHA strategy is a AAA strategy. So we do have advocacy, but it's not alone. It comes along with analysis and with action. And what is this? Again, it's us. The analysis asset we do have. Analysis asset is data availability, as you were mentioning, data sharing, data quality, data analysis, and interpretation. And this is the evidence that we all produce in our PhD programs.
So the European health data space is something that EUPHA is eagerly also looking forward to.
Yes, also in this program, and last year we have been discussing together with the European Commission and other stakeholders around what is the potential of European health data space for protecting health of citizens, as it's solid rationale, but also for other uses. And they all fit within the EUPHA mission.
Thank you for bringing that slide up, Anna. It's good also to remind ourselves. Analysis, we've heard from Alisha that there are evidence gaps and that we saw those arrows horizontally, meaning that basically there is some evidence, but it's not enough yet to be able to show us where the trajectory of travel lies. Advocacy, if each and every one of us, every time we are given the opportunity to speak to communities, to policymakers, to universities, can continue to highlight the importance of equity as we pursue digitalization. We heard from David, there's no stopping this. AI is moving forward, is learning from itself. The whole digitalization of health systems has been accelerated by the pandemic, but we have to actually support the transformation because we know that there will not be enough health and care workers to continue to do things in the way we have always done them. So we need to make sure that as this continues to hurtle forward, we don't leave people behind, but also that it does not become the cause itself for a new set of inequities and inequalities. And I guess the European Commission and WHO will continue to stand through the regulatory and legislative powers, through the advocacy powers that we have together, to ensure that we support the actions that need to be taken to pull this together, and in a measurement framework to hold everyone to account so that there is no backsliding, and if we have identified baseline inequities, that we move forward to be able to close them without generating new ones. This brings us to the top of the hour. I would really like to thank our presenters and panelists for sharing their rich and valuable insights in a very open manner, for also having taken some questions that hadn't been pre-prepared. Thank you for being spontaneous, and thank you for landing us in time for our next sessions. Thank you everyone for joining us.